Okay, let's dive into this. Welcome to this explainer on mastering documentation for physical therapy. Today we are taking on a genuinely massive goal, and that is defending your physical therapy claims against audits by perfecting exactly how you document. If you want to make absolutely sure the skilled care you provide is actually recognized and, more importantly, reimbursed, well, you're in exactly the right place.
We've got a highly focused syllabus today. 1. The power of proper documentation. 2. Evaluation complexity. 3. Initial evaluation medical necessity. 4. The plan of care. And 5. A preview of our masterclass finale. Let's get to it.
Section 1. The power of proper documentation. You know, clear, accurate documentation isn't just administrative busy work. It's literally the absolute foundation of your practice. It is the only definitive way to establish medical necessity and secure fair payment. To an auditor, if it isn't documented, it simply didn't happen. Period. As a clinician, you can't just summarize the objective findings of other people. Think about it. Auditors don't have imaginations. They need to see the patient through your expert eyes. So you have to paint a vivid, detailed picture of their specific impairments, and crucially, you've got to describe their prior functional level. That baseline is exactly how you establish the patient's rehabilitation potential and ultimately justify our prognosis.
Let's move to and see how this builds into Section 2, PT Evaluation Complexity Levels.
Let's decode the specific CPT codes that categorize your initial encounter. So, the crucial point is that every single physical therapy evaluation is built upon 4 core components. First, you have the patient's history, which means looking at their personal factors and any comorbidities. Second, you have the examination, where you're utilizing standardized tests to look at body structures and activity limitations. Third, you have your clinical decision-making process. And finally, you have the stability of the patient's clinical presentation. These 4 variables are exactly what dictate the specific complexity code you are legally allowed to bill.
Escalating from low to moderate to high complexity is really a game of strict thresholds. For low complexity, that's CPT 97161, you're looking at 0 complicating comorbidities, a stable presentation, and it takes about 20 minutes of face-to-face time. But the second you hit 1 to 2 comorbidities, 3 or more elements, and an evolving presentation, boom, you jump to moderate complexity, which is roughly 30 minutes. To legally justify high complexity, CPT 97163, you've got to document 3 or more comorbidities, 4 or more elements, and an unpredictable presentation requiring about 45 minutes of face-to-face time. You absolutely must hit and document these strict thresholds to justify billing those higher codes.
Which brings us to a really important question I want you to consider. When is a formal reevaluation, specifically CPT code 97164, actually medically necessary? Think about your day-to-day practice for a second. Is it just when you're checking on a patient's progress during a routine Wednesday afternoon visit? Well, the answer to that is a definitive no. To legitimately bill CPT 97164, you need very specific clinical triggers. We're talking about new clinical findings, a significant and totally unanticipated change in the patient's condition, or a complete failure to respond to the interventions outlined in your original plan of care. It requires creating a revised plan of care, involves about 20 minutes of face-to-face time, and it has to contain all the applicable components of an initial evaluation. Look, continually assessing a patient's progress is just expected as part of ongoing therapy services. But that everyday routine assessment time, that's just bundled right into your regular treatment CPT codes. You don't bill it as a separate reevaluation.
Moving right along to Section 3, Initial Evaluation Medical Necessity.
Okay, so we know the complexity codes, but what actually makes that initial evaluation completely bulletproof to an auditor who is scrutinizing the medical necessity of your care? It comes down to a highly logical progression. First up, you must clearly document the presenting complaint specifically as it relates to that visit and select the perfectly correct ICD-10 diagnosis. Second, establish that prior level of function. Third, you have to identify any social or environmental barriers that could potentially throw a wrench in the recovery trajectory. And fourth, you must perform objective impairment testing. Following this exact sequence is what justifies the skilled nature of the therapy being provided. It proves without a doubt that the patient actually requires a licensed professional. And this brilliantly illustrates a common trap. If you rely on vague descriptors like patient has poor shoulder mobility or patient seems a little weaker today, the auditor's rubber stamp is heading straight for the denied pile. Vague simply doesn't cut it in this industry. You have to use exact range of motion degrees and standardized objective testing data. Precise, hard data is exactly what proves beyond a shadow of a doubt that your specific type, frequency, and duration of therapy are medically necessary for this individual patient's unique condition.
All right, let's look at Section 4, Plan of Care and Certifications.
Creating the plan is really just step one. Keeping it perfectly compliant over the entire course of treatment is where the real administrative challenge lies. Every single compliant plan of care has to include a few mandatory elements: measurable long-term functional goals, the specific type of treatment, the amount of treatment, the frequency, and the overall duration. And I really want to emphasize a foundational rule here, guys. A therapist absolutely cannot initiate treatment without an evaluation and without this established plan of care firmly in place. The plan always dictates the care.
And once that plan of care is established, the clock immediately starts ticking. You have a very strict 30-day deadline for the physician or non-physician practitioner, the NPP, to sign and certify that initial plan. Therapy services must be furnished while under the care of a physician, and if they don't sign off and certify this within that unforgiving 30-day window, your billing is fundamentally compromised.
But it definitely doesn't end there. 90 days is your next critical number to remember. This is the absolute maximum deadline for recertification. To maintain ongoing compliance and, let's be real, to ensure your revenue stream isn't suddenly halted, the plan of care must be recertified by the physician or NPP at least every 90 days.
Now, let's map out the ongoing timeline for progress reports, because the distinction here trips up a lot of clinics. Day 1 is your initial evaluation. Easy enough. After that, you need a progress note every 10 treatment days. Notice I specifically said treatment days. That means days the patient is physically in the clinic receiving care. However, you also have a hard, non-negotiable deadline of 30 calendar days for a progress report, entirely regardless of how many actual treatment days occurred in that span. You literally have to track both of these timelines simultaneously to stay perfectly compliant.
Finally, on a day-to-day basis, your daily encounter notes require extreme precision. You must explicitly separate and document both your timed code minutes and your total treatment time. This separation isn't just a suggestion, it's strictly required to correctly calculate and justify the specific units you're billing, especially when you are dealing with the 8-minute rule. For example, say you do 7 minutes of therapeutic exercise, 7 minutes of manual therapy, and 7 minutes of neuromuscular re-education. Your total timed treatment is 21 minutes. Because of the rules, you can only bill 1 unit total for that time, and you have to select which of those 3 specific codes you're going to bill it under. If you don't track those exact minutes, auditors will invalidate the units in a heartbeat.
Which brings us to Section 5. Next up, our masterclass finale.
We have covered some truly incredible ground today to bulletproof your documentation. From decoding those tricky evaluation complexities to mastering the strict certification timelines, you now have the exact blueprint. But there is one final crucial piece of the puzzle. In our grand finale, Part 15, we are going to crack the code on crucial modifiers like 59, KX, GP, and GA. Are you accidentally leaving thousands of dollars on the table just because you're applying these modifiers incorrectly? Find out next time and achieve total audit-proof compliance. Until then, decode healthcare with Harshal.